Hi doctors, how are you? Welcome to a new chapter in oral surgery. I hope you start to enjoy the material now. So up till now we discussed about the principle of extraction, complicated extraction, which is related to the flap techniques. Now we are going to discuss about complication that it's not very common to happen in the clinic, but it's really dangerous and you need to care about it. This chapter and the following chapter discussing about fracture, I cannot remember any cycle with no question about these two chapters. So these two chapters are really critical, and please watch this video at least twice and before your exam, because this is really important and it's easy concept. Just once you understand it, it will become easier. This one and the fracture one. Let's start with our question first. Okay, so this chapter discuss more about complicated, uncommon problem might happen after extraction, like space infection and oro-antral communication. So this oro-antral communication means the sinus to the oral cavity. But let's discuss first about the space infection. Odontogenic infections are primarily caused by bacteria that are part of the normal flora. These bacteria include anaerobic gram-negative and anaerobic gram-positive cocci and anaerobic gram-negative rots. So it's cocci and rots. The infection typically polymicrobial. It's not like only one bacteria. The most common bacteria as aerobic infection includes Streptosanguis, Streptointermedius, and Streptoconcentratus. An anaerobic bacteria commonly found is related to Brevotella and Bromonas and Fusobacterium species. Why I'm saying the names? Because sometimes asking about the most common name of bacteria. Yes, I know this is not easy, but at least know the names. When you go perio, you will memorize all the names. Don't worry. In the perio, you should know it because it's most common in the perio to ask you this condition is not caused by which bacteria, but which one is the most commonly reason for this such infection. Okay? It's annoying, but sorry. Please do it. If you didn't do it now, okay, no problem. When you go perio, you will do it anyway. Okay. The infection progresses through stages. First is inoculation, second is cellulitis or abscess, which with the type of bacteria present changing as the infection evolves. So simply and easy discussing, this is what is going to happen. So you have a tooth with necrotic pulp. This necrotic pulp ends up by granulation. This granulation, soft tissue, your body would like to get rid of the soft tissue. So soft tissue is applying pressure. So if the tooth apex is related more to the labial side, buccal side, it will erode through the buccal plate of bone, leading to infection in the vestibular space. Or if it's related to the palatal bone, it will erode easier to the space here is easier to go here. So it will go to the palatal side, ending up by space in the palatal side. And there is one more factor, which is the location of this erosion to the muscle. So this is like the buccinator muscle. So if the erosion of the infection happen below the muscle attachment, it will end up by vestibular swelling. And if this infection erode above the attachment of the muscle, it will end up by buccal space swelling. So this is the main criteria when you have infection. This infection eroding through the bone is related to the apex, related to buccal or palatal bone, and the location of this erosion. If it happens below the muscle, it will end up by vestibular space infection, or if it end up above the muscle attachment, it will end up by buccal space infection. Okay, so erode through the bone, tooth apex is near to the labial, end up by labial, palatal, end up by palatal. Relation of the bone perforation to the muscle attachment. When the tooth apex is lower than the muscle attachment, vestibular abscess result. If it's the higher than the muscle attachment, it will end up by fascial space is involved. So the reason why it might end up by abscess or the fascial space infection is related first and most is the host immunity. If you have host immunity compromised, second is related to the virulence of the bacteria and the infection, and third is related to the location where it's going to happen. So it's happening here, vestibular. It's happening beyond, it's related to be buccal space infection. And this is a difference between both inclusion, cellulitis, and abscess. So duration, inclusion, which is usually edema, happen in this way. 0 to 3 days, cellulitis 1 to 5 days, abscess 4 to 10 days. The main difference between cellulitis and abscess is the border. In the cellulitis, we have diffuse. In the abscess, we have localized. Because cellulitis, most likely, it will go to space. And the size, as go to space, it will be large, it will be red in color and broad-like in the consistency, and it's increasing because the infection is moving in the spaces. And the pus is absent. Why? Because the pus is inside the facial spaces. Bacteria is mixed, and seriousness, this is greater because this infection might lead to space in spread of infection in different location inside your body. So it's related not only to infection, it's related to the location and related to the immunological of our patient. So this is the difference between cellulitis and abscess. So I would like to confirm cellulitis is more diffuse and is more dangerous. Edema is like most commonly is the seriousness is low because it's related to this area only. Okay? Okay. The principle of theory of therapy for odontogenic infection as follow. First of all, determine severity of infection. So this infection, as we said, is cellulitis or the abscess. Evaluate status of the patient host defense mechanism. If the patient has medical condition or compromised immune system, so this patient we need to take care more carefully with him. Determine whether patient should be referred to specialist or you can deal with him. So you should refer him to specialist or not. And if you would like to treat it surgically or you would like it only to treat it like with local measurement or only antibiotics, so this is really important. And support patient medically, choose and prescribe appropriate antibiotic, administer antibiotic properly, mean like the good regimen, correct regimen for the correct duration, and evaluate patient frequently because it might start as abscess, end up by cellulitis. So this is how we're gonna think about this. So history, pain, swelling, caries, periodontal condition, end up by odontogenic infection. First of all, you are going to do X-ray and assess severity if it's compromising airway leading to load-wing angina, so it's totally different manipulation. And then in this condition, you are going to refer him to ortho specialist or surgical specialist, or it's the outpatient. So in inclusion stage, you remove dental cause, extraction, and debridement of if he go to cellulitis. So initially you will go incision and drainage, and then you remove the dental cause. So before we said incision and drainage is only for cellulitis, abscess not, but this is from before. Nowadays, if you have any swelling is related to abscess, so incision and drainage is the first line of treatment. Incision and drainage is the first line of treatment. And then you follow up with the patient according to the medication you are going to give to him. Okay, so this is the cascade or the algorithm how you are going to deal with the patient with odontogenic infection. So we discuss a lot about open and drain. So what's the open and drain? So open and drain, as you can see here, we have a tooth here with infection. This infection coming here in the vestibular space. So first of all, the infection did erode through the palatal bone because as you can see, the location to the palate is shorter than location to the lingual plate of bone. Abscess is incised with number 11 plate, break with a hemostat after you do it. This is the incision, and then you break it with hemostat to break up any lobulation of pus that may exist here. And then you do put a small drain here, and this small drain is sutured and left inside the oral cavity so it can drain the pus outside. So as you can see here, this is not a cellulitis. We here end up by abscess, and abscess initial management is open and drain. So abscess initial management is not extraction, it's not RCT, it's not antibiotic. The initial management of any abscess or cellulitis is open and drain. And here you understand, you use a plate number 11, and then you use hemostat to break the lobulation of pus, and then you put a drain and you suture it, and then you follow up with the patient. Okay. Indication for therapeutic use of antibiotics. So this is the indication only for antibiotic. This is the only indication for antibiotics. So please pay attention to this because you might trick you with this. Swelling extend beyond the alveolar process, cellulitis, trismus, lymphadenopathy, temperature higher than 101 Fahrenheit, severe pericoronitis or osteomyelitis. So you see here, this is the main indication. If you didn't catch the concept, here, let's see. situation in which use of antibiotic is not necessary. Patient demand severe pain, toothache, periapical abscess. You see here, periapical abscess, dry socket. No, if you remember from previous lecture, dry socket, periapical abscess, not necessary. And this table, I didn't invent them. This is strictly right from the textbook. I take a screenshot and bring it here because I know like if I discuss it, it will be like confusing. How come we don't give this one for such conditions? So this is the strict requirement to give antibiotic for your patient. Multiple dental extraction in a patient who is not immunocompromised. So multiple extraction, give antibiotic? No, unless he is immunocompromised. Mild pericoronitis, see, mild pericoronitis, no, you don't give him antibiotic. Finally, drained alveolar abscess. So if you have abscess that is drained, you don't give him antibiotic, okay? So this is the indication for antibiotic. Effective antibiotic pen, for sure, amoxicillin, but like Clinda now is not very common, azithromycin and moxifloxacin. Compromised host defense, when you say patient has a compromised, uncontrolled metabolic, poorly controlled diabetic, alcoholism, malnutrition, end-stage disease, immune system suppressing disease like HIV, lymphoma, other malignancy, or immunosuppressive therapy like cancer therapy and corticosteroids and organ transplant. Sometimes we aim to the narrow spectrum, which is pen amox clinda, and broad spectrum, which is this amox and clovalnate, azithromycin and moxifloxacin is the advanced antibiotic. So out of this picture, I would like you to understand every space infection we are going to start with incision and drainage, and not all the space infection will give antibiotic. You hope you catch the concept and you really understand it, because this will solve a lot of mystery going forward and a lot of mystery and the questions. Okay? Okay. Odontogenic infection usually mild and readily treated with appropriate surgical procedure with or without supplemental antibiotic therapy. Infection that is spread beyond the teeth into the oral vestibule are usually managed by intraoral incision and drainage procedure, as well as dental extraction, root therapy, or gingival curettage as appropriate. As infection erodes through bone, it can express itself in a variety of places depending on the thickness of overlaying bone and relation of muscle of mastication. Okay, so let me give you like breaking news here, because like this was confusing me for a huge amount of time. So when I'm telling you buccal space, palatal space, sublingual space, so this is when you hear this word space, you think it's physical space between the soft tissue, which is wrong. This is, to be accurate, is a potential space. What the meaning of potential space? So when you discuss about buccal space, like here number 2, here this buccal space is between the buccinator muscle and the fascia in this area. So is there a space here with nothing in this area? No. There is muscle and fascia over it. So when the infection goes, it will go to the least resistance. So compare bone to this one, it will go here. So it will lead to space in this area. So whatever is written here, they are potential spaces. It's not a space, really space. So vestibular abscess here, as we said, in the lower arch above the attachment, and in the lower arch above the attachment, and the upper arch below the attachment. Buccal space in the lower arch when you go below the attachment, in the upper arch when we go above the attachment. Palatal space when you go to the palatal side, as you see number 3. Sublingual space when you go above this watch muscle, mylohyoid muscle, submandibular gland, sublingual gland, and submandibular gland. If you remember from anatomy, submandibular is below the mylohyoid muscle, and sublingual is above the mylohyoid muscle. So if it ends up above mylohyoid muscle, it's sublingual space infection, which will end up by intraoral swelling and elevation of the tongue. If it ends up below mylohyoid muscle, it will go to number 5, which is submandibular space infection, which will end up by swelling extraorally at the angle of the mandible. And finally, maxillary sinus when it comes to the upper posterior molars. So I hope you catch the concept here. Space here are potential space. It's not really space happen. And why the infection goes to this soft tissue? Because it's easier to go to soft tissue than to erode more bone. Okay. Here I write each space and the component and content and neighboring space approach for incision and drainage. This is not to be memorized. This is just to give you aspect, like to give you perspective where this spaces are, and this picture is including here. Okay. We are going to divide the space infection according to, I think, 2 or 3 criteria. The first criteria is the source. Any tooth in the oral cavity can lead to vestibular space infection, buccal space infection, or subcutaneous space infection. And infection coming from maxillary teeth, and infection coming from mandibular teeth, and infection in deep fascial space. This deep fascial space, we can consider it to be secondary space infection. So all this are primary space infection. Why? Because it coming directly from one tooth to the space itself. But here, deep fascial space, lateral pharyngeal, retropharyngeal, pretracheal, danger zone, and prevertebral, all this, there is no teeth related to this space. So we're going to call this one what? The deepest secondary spaces. Secondary space infection or primary space infection. This is how usually they divide it. So again, this picture, this not to be memorized. This just when you are confused, how come this will lead to infection in this space? So when you read this one, it will become like easier. Let me give you an example. Lower third molar most commonly will end up by space in the submandibular infection. And the lower premolar and lower molar 6 and 7 will end up by sublingual. Why? This is related to mylohyoid muscle. Mylohyoid muscle, if you remember from anatomy, insertion is coming inside the mandible in the mylohyoid line. This mylohyoid line is going this way, going inferior as you go from posterior to anterior. So it starts below the area of 7 and then fade anteriorly and inferiorly. This is the mylohyoid line where the mylohyoid muscle is present. So this mylohyoid muscle, posterior to it, you have the 8. So most commonly, infection from 8 will end up below the mylohyoid muscle, which will end up by buccal. If we discuss about 6, 4, and 5, it will be superior to will end up by lingual. Again, this is just to visualize it to make it easier for yourself. Okay? And then here we discuss about the masticator space, boundaries, superficial space, lateral pterygoid, zygomatic arch. So again, this is all just for visualization. In this topic, I would also discuss about this cavernous sinus thrombosis. We discussed this one in anatomy. Please go back to it if you are really confused about it because it's important. But like here, from the surgery aspect, I would like to confirm about the spread of infection. So spread of infection from the jaw to the cavernous sinus may occur anteriorly via inferior or superior ophthalmic vein, posteriorly via imaginary vein from pterygoid plexus. So usually they will ask question this way. Infection coming from cavernous sinus anteriorly through, posteriorly through. So this is a question usually coming from this one. And the cavernous sinus thrombosis signs and symptoms, we discuss it in anatomy. Okay? And here, just to confirm about this location, buccal or palatal or lingual, and this is above and this is below the muscle attachment. Okay, so let's discuss about the space infection itself. So infection arises from any tooth. We have vestibular space infection, buccal space infection, and subcutaneous infection. So this infection is spread superficially. This infection coming in vestibule or the buccal is related to the location of the apex. So in upper, it will be above the muscle. And in lower, it will be below the muscle. So please read the question carefully. So buccal space infection coming from upper teeth because apex is related to above the attachment. In the lower arch, it will be below the attachment. Okay? Okay. Management, incision, and drainage are performed often intraorally for a smaller abscess and extraorally for larger one. This type of infection may be buccal, but like most commonly, we are going to do it intraorally. Antibiotics are prescribed based on the severity and extent of the infection. Okay? Okay. Infection arising from maxillary teeth. It might end up infraorbital space coming from maxillary canine. Infraorbital maxillary canine. Buccal space coming from molar. Infratemporal space coming from maxillary third molar. So this is the question. Infection in the infratemporal space most commonly coming from which tooth? Maxillary sinus coming from posterior maxillary teeth. Cavernous sinus thrombosis caused by infection spreading through the infratemporal or ophthalmic vein. So infratemporal coming from maxillary canine. So the infection, anterior infection coming to cavernous sinus leading to cavernous sinus thrombosis is related to which tooth? Maxillary canine or maxillary third molar? Yes, maxillary canine, because here he's asking about anterior space of anterior route of infection. If the infection coming inside the cavernous sinus from posterior aspect, it will be coming from maxillary third molars through infratemporal space infratemporal space will lead to pterygoid venous plexus, and this will lead to infection here through the imaginary vein or pterygoid venous plexus. Okay, so I hope you catch the question now and you can understand it and answer it. I'm not here to like let you memorize the answer. I would like you to understand it and visualize it. Management, surgical drainage is essential, often requiring extraoral approach, as you can see for this one, and high dose of antibiotic administrated because we have a space infection here, which is big. In severe cases, hospitalization may be necessary. Infection arising from mandibular teeth, space of the body of the mandible, which is supraperiosteal infection that appear if the mandible itself is enlarged. So you feel the mandible here is coming big in the side, angle of the mandible. Submandibular space, mandibular third molar. Sublingual space, mandibular premolar first molar. Submental space, infection from mandibular incisors. Masticator space, which is posterior, related to mandibular third molar. Okay? Management, aggressive surgical drainage, require multiple incision and placement of drain, and high dose intravenous antibiotic are administered. Why we address this one more aggressively? Because this is related to the airway. If it happened in the airway, it might lead to cannot breath, so he will be dead. So this is why it's more aggressive treatment. Finally, the deep cervical fascial space, which is, we can call it secondary space infection. Lateral pharyngeal space, infection spreading from submandibular or sublingual. So there is no direct route from the tooth to the lateral pharyngeal. Retropharyngeal space coming from lateral pharyngeal space. Dangerous space from retropharyngeal space to the mediastinum, so inside the body itself, mediastinum necrotizing fasciitis. So this too is related even to vital structure like heart and lung, and this is like, I have a picture I didn't add it because like it's very like, gross picture, like infection coming this area, so he need to remove all the skin from here. So this is not related to the virulence of infection, it's related to compromised immune condition of the patient. And this is why in such condition, immediate surgical intervention to secure the airway and extensive incision and drainage and hospitalization is required. So when you come, the infection coming in this spaces, no, this is really dangerous and it's life-threatening condition. Okay, let's divide the space infection to intraoral swelling, extraoral swelling. Intraoral, we have the sublingual space infection, mandibular premolar and first molar, elevating the tongue, intraoral incision. Again here, I would like to confirm, we discussed it before, but just to confirm, here you see sublingual abscess above mylohyoid muscle. Submandibular is below the mylohyoid muscle. And this submandibular can split to lateral pharyngeal and retropharyngeal. And this is why it's really, really dangerous. So intraoral, we have sublingual and vestibular coming from any tooth, area between the gum and cheek lip. Management, intraoral incision for and drainage for a condition, okay? And when we go to infection with extraoral swelling, I think all of the other condition end up by extra oral swelling. Buccal, posterior maxillary teeth, below the zygomatic arch and above the mandible, so swelling will be here. Infraorbital space will be here, coming from maxillary canine, obliterate the nasolabial fold. So the question will tell you swelling obliterating the nasolabial fold. Which of the following most likely the source of infection? Okay, I think you catch it now. Submandibular space infection, mandibular third molar, inverted triangle pro the mandible coming here and might lead up to swelling in the angle of the mandible, like this one. You see this one? I don't know, once I see this picture, I remember Michael Jackson, I don't know. Anyway, submental space infection coming from mandibular incisor, central submandibular region. So this is space infection. We might think it to be like submental because like most commonly submandibular will become more posteriorly. Submasteric space infection, this is more posteriorly, mandibular third molar or buccal space spread. So this coming from 8 or coming from buccal of lower 6 and spreading to submasteric space infection. So this is, we can qualify it to be lateral secondary space infection. And lateral pharyngeal space infection from submandibular or sublingual, angle of the mandible, and anterior to sternocleidomastoid, this muscle, sternocleidomastoid. Okay, finally we have the most dangerous one, which is Ludwig angina. So it's a severe, rapidly spreading cellulitis involving bilateral submandibular, sublingual, submental. So everything here is infected and swelling. This condition is potentially life-threatening. Why? So this is coming from infected mandibular, maybe from trauma. Clinical feature, swelling. We have three swelling in the floor of the mouth. This one might end up by tongue elevation, the tongue elevated and displaced posteriorly, which can obstruct the airway. This is the main criteria where this condition is really important to have immediate surgical management and immediate hospitalization, because you have a swelling here related to the area compressing the airway, and also it's elevating the tongue. Let's see the picture before we discuss English. You see here, so some base, both some lingual, both some mandibular elevation of the tongue. You close the airway here, and you compressing over the airway here. So this is why it's really important for such a condition to have immediate management. What's a clinical feature? Swelling, tongue elevation, trismus, because muscle of mastication is compromised, drooling, inability to swallow saliva, and difficulty swallowing, which is dysphagia, and dyspnea. Dyspnea is difficulty breathing. So this is the main three words for Ludwig angina. Drooling, inability to swallow saliva, dysphagia, difficulty swallowing, and dyspnea, which is difficulty breathing, are common in such condition. Fever, malaise, patient often present with systemic sign of infection because you have infection everywhere inside your soft tissue. Management, airway management, and this is the primary concern. We don't care now about extraction of the tooth and getting rid of the infection. We care about the airway management first. Even sometimes endotracheal intubation or tracheotomy may be necessary for such patient if there is significant airway compromise. Surgical intervention, for sure, incision and drainage, and removal of the source. So first we have this airway, second incision and drainage, and finally removal. Antibiotic, in this case, high-dose intravenous antibiotic, pen, clinda, or metronidazole. Supportive care, ensuring adequate fluid and pain management for the patient. Prognosis, prompt and appropriate treatment. The prognosis is generally good. If it's not and it's delayed, it might end up by airway obstruction, and sadly, the patient might be dead. Okay? Okay. So again here, the primary space infection, secondary space infection, this table to give it to you. So let's see here. So the primary space, maxillary canine, infraorbital, maxillary molar, buccal, mandibular molar, submandibular, sublingual. Secondary, buccal space infection getting into infraorbital space, or submandibular infection spreading to the lateral pharyngeal, or sublingual infection spreading to retropharyngeal. So it's coming from not a tooth, it's coming from other space infection. So space infection is extremely important. Please study it in depth because this is critical. I cannot remember any cycle without question from this one and the trauma, the fracture of the face. Okay, one more complication that might happen for the patient after extraction, which is osteomyelitis. So this is infection of the bone, typically starting in the bone marrow and spreading to the cortical bone and periosteum. Causes, most commonly odontogenic infection, sometimes due to fracture or compromised host defense. Pathophysiology. Bacteria invade the cancellous bone, causing inflammation and edema. Increased tissue pressure lead to compromised blood supply, resulting in necrosis of the bone. So you have infection, this infection leading to inflammation, this inflammation leading to edema, this edema compromised, let's see the picture here. So this is swelling lead to compromised blood supply coming in this area. When you have compromised blood supply, so your bone cannot heal, so it will end up by necrosis of bone marrow, and necrosis of bone marrow will end up by more pressure over the area, so less blood supply, and it goes on and on. So you can see osteomyelitis is diffuse radiolucency coming in this area. Let's zoom in here. Diffuse radiolucency coming in this area. So it's infection, but your body cannot deal with that infection. So if your body cannot deal with that infection, it will end up by this like ball of ice, this avalanche when the ice happening and then boom, 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 till everyone is like under the ice. So the same condition here. So this is why it's really important to think about the compromised host defense. And all this chapter is related to compromised host defense because not everyone with abscess, it will end up by fascial space swelling or end up by Ludwig angina. It's related mainly to compromised defense of our patient. Common site, mandible, because mandible has limited blood supply compared to maxilla. Symptoms, pain and swelling, fever, malaise, and pus discharge coming from the infection. How we diagnose it? Swelling, pain, and pus discharge. So this is enough to say this is osteomyelitis. radiolucency in acute cases, and then we do culture and sensitivity testing to see pus and or bone sample in this one. How we are going to treat it? You are going to treat it with high dose of antibiotic, Clinda, penicillin, fluoroquinolones. So why he start with clindamycin? Because most commonly this infection coming from anaerobic bacteria. So in such condition, the main action or the main choice of antibiotic coming to be clindamycin, not penicillin, unlike the other old medication. So as a rule of thumb, all dental infection we treat it with penicillin. We treat with penicillin unless three only condition we usually pick other than penicillin to be the first line. First, when the patient has allergy to penicillin, so we cannot pick penicillin. Second, if you have infection and osteomyelitis, you are going to pick clindamycin. And third, when you have perio condition, when you have periodontal infection, most commonly we end up by picking metronidazole over penicillin. When you go to perio, we're going to discuss it, but as a general rule, penicillin is our golden standard. Unless patient has allergy, or the patient has osteomyelitis, or the patient has periodontal condition, we are going to favor metro for periodontal and clinda for osteomyelitis. Intravenous antibiotic for severe cases. Surgical management, debridement, removal of necrotic bone and infected tissue, and removal of causative factor for sure. And sometimes we end up by doing choroteectomy. Choroteectomy mean you have bone here and you have a swelling, so you are going to drill into the bone to get rid of the pus. So it's like incision and drainage in hard tissue. Removal or perforation of the bony cortex to improve blood supply. So you're getting rid of the pus and leave the area for the blood to come to heal the condition. Stabilization, ensuring immobility of the fracture segment in case of the jaw fracture, and this will be discussed in depth in next chapter. Prognosis, acute osteomyelitis, although it's rapid and it's painful, generally respond well to antibiotic and surgical intervention. Sadly, chronic osteomyelitis may require prolonged antibiotic and aggressive surgical management to prevent recurrence. So this is the osteomyelitis, and this is how it appears. So the question usually comes where the osteomyelitis infection start in the bone, not the cortical bone, the bone, spongy bone start, and then spread everywhere, okay? And it's related more to the immunocompromised condition. Amazing. Finally, let's discuss about maxillary sinus. Okay, so sometimes they ask question basic about maxillary sinus, not very common, but like I will give you some information about maxillary sinus. So maxillary sinus is air containing space in the maxilla. You see this way. This is the like frontal, and this is the from lateral view. Okay, so this is space. Maxillary sinus, also known as antrum of Highmore, or the antral, or antrum of Highmore, is a four-sided pyramid with average size 34, anterior posterior 33 in height, 23 in the width. I don't want you to know all this information, just write it just in case, and holding a volume of 15 to 20 milliliter. What's the problem with maxillary sinus? The sinus is lined with respiratory epithelium, it's not oral epithelium, which includes cilia. This can move mucus and foreign material toward the ostium. So what's the ostium? So because we have a space here, this space has mucus. So if the mucus has nothing to kick it out of the maxillary sinus, you might end up by stagnant mucus here, which is perfect medium for bacteria to grow. So we have this respiratory epithelium with cilia is giving stroke up to 1000 stroke per minute to kick out the mucus at 6 millimeter per minute. So this is the number, 1000 stroke per minute to kick out mucus at rate of 6 millimeter per minute to kick it out through ostium. So if this ostium is blocked, so it will lead to accumulation of mucus. Accumulation of mucus in this area will lead to bacteria overgrowth, which will lead to infection. This infection might come as non-odontogenic infection, typically caused by bacteria that are usually found within the nasal cavity. This infection can result from inflammation due to infection, allergy, neoplasm, leading to hyperplasia and hypertrophy of the mucosa, which may obstruct the sinus ostium. When the ostium is obstructed, mucus accumulate, potentially leading to bacterial overgrowth. The bacteria commonly associated with non-odontogenic maxillary sinusitis. Yes, I know you are saying why this man is giving me this information. That was a question. What's the bacteria most commonly associated with non-odontogenic maxillary sinus infection? Streptococcus pneumonia and H. influenza and Primamella. So why? Because we said this is lined by respiratory epithelium. So you see here all the bacteria is not related to us as a dentist. Streptococcus pneumonia, H. influenza, and Primamella. Okay, as well as anaerobic Streptococcus fridans and Streptococcus aureus. I read the other name. I don't encourage you to memorize it. Just know it because this is one of the outlier question. So the question about the rate of the drainage of the sinus, the question about which bacteria is related to non-odontogenic infection of maxillary sinus. This is the type of question I call it silly question. It shouldn't be asked for us as a dentist. But again, when you see it in the exam and you pick it correctly, you feel like, oh, I am over the moon now. So just know it and move. Do not invest more time about it. These type of question, I'm trying to get the answer to be very short and concise to the question. Okay? Because this is not related to us as a dentist. But like when you answer it, you feel so happy. Okay? Maxillary sinus, now discussing about non-odontogenic. So it might end up by acute. Acute means rapid, sudden, lasts less than 4 weeks, is severe, pressure, pain, fullness of affected sinus, foul smelling mucoperiosteal material coming from here is due to bacterial infection because we said the ostium is plugged or sometimes viral infection. This one requires immediate attention and aggressive medical care including decongestant, needle spray, pain relief, and antibiotic if bacterial infection is suspected. Okay, antibiotic and the name of bacteria is here. I think the question, the answer was this one. And everyone was like crazy, like influenza is related to, yes, because it's coming from respiratory epithelium. It's not coming from oral epithelium. Okay? Okay. Chronic maxillary sinusitis, gradual and persistent, lasts for 12 weeks or longer. Symptoms less intense because it's chronic one. May flare up periodically, so it's not sometimes up, sometimes down. It has low-grade bacterial or fungal infection. Complex treatment include long-term antibiotic, nasal corticosteroids, and possibly surgical intervention. So if you are still confused about maxillary sinus, this is a maxillary sinus. Okay, you see it in the oral cavity. Okay, and this maxillary sinus has something like important. I will not say it. I hope someone in the live session will tell me about it. And this two maxillary sinus, there is something pathological here. So I would like you to tell me about it. Okay. Okay. How about odontogenic infection? Odontogenic infection coming from dental source, close anatomical relation of upper posterior teeth, approximately 10 to 12% only of all maxillary sinusitis coming from odontogenic cause. Cause, periapical disease related to the root tip of the tooth itself, periodontal disease, gum or supporting structure, dental trauma in this area, or surgery. Surgery might end up by communication between oral cavity and maxillary sinus, and this is what we call oro-antral communication, and this is our next topic. Common bacteria, aerobic bacteria, predominantly aerobic bacteria, anaerobic bacteria, such as bacteroid, enterobacteriase, Biptycoccus, and Pseudomonas, and Brevatella, and Eubacterium. So, odontogenic infection in maxillary sinus is related to dental bacteria, which is Pseudomonas, Brevatella, and Eubacterium. And aerobic bacteria, aerobic and anaerobic streptococci. Okay, so most commonly odontogenic coming from Brevatella, Eubacterium, and Pseudomonas. And for this name of bacteria, when you go to perio, I will give you like a schematic diagram to discuss about it to make it easier. It will become easier, not so easy, but like it will become easier in a way. Okay, symptoms similar to non-odontogenic sinusitis, including facial pain, pressure, and nasal discharge, and possibly dental pain. Complication: if left untreated, odontogenic infection can spread to other paranasal sinus, potentially lead to serious conditions such as orbital cellulitis and cavernous sinus thrombosis. So you see here this picture, you have remaining root inside maxillary sinus, and here you have impacted tooth inside the maxillary sinus. So you just do x-ray and you see it. And when you see it, you should deal with it. So if you remember, we said incision and drainage is the main treatment. For this one, incision and drainage is done through this lovely surgery. So you are going to open a window in the maxillary sinus in the most anterior part above the canine eminence. So this is central lateral. This is the canine, I think. Yes, this is the canine. And just above the canine, you are going to put this, what we call Clotwell-like exposure of maxillary sinus. through vestibular incision and bony window created in the anterior maxillary wall. So cloud will lack exposure is happening in the posterior wall, medial wall, lateral wall, anterior wall of maxillary sinus. Why we do it? We do it because we have foreign body inside the maxillary sinus. Whatever antibiotic, whatever treatment you are going to do, it will be nothing. So this is the incision and drainage for the maxillary sinus through this type of surgery, and it's done just posterior to the maxillary eminence, canine eminence here, okay? And then you are going to give antibiotic. As you can see here, penicillin with this odontogenic infection. You're going to pick penicillin. Clinda for pen allergy. So this one they didn't update the guideline yet. So I think we are not going to do clindamycin here. We are going to pick metronidazole again because it's coming from the anaerobic realm. Okay. Combination, sometimes amox and clovelinate as augmentin for this one. Surgical intervention may be necessary to remove the source of infection, such as extracting an infected tooth or performing procedure to close any communication between oral cavity and the sinus. And then we can do culture sensitivity to pick which antibiotic to be given for such a condition. So this is the surgical technique we are going to use to get rid of any foreign material inside the maxillary sinus. Okay, how about oro-antral communication? So oro, which oral cavity, antral, which is the other name of maxillary sinus, communication, which means connection. So this causes of oro-antral communication, tooth extraction, especially the maxillary molars, or trauma or surgical procedure when you do sinus lifting and boom, you have the implant inside the maxillary sinus now. How to avoid it? Pre-surgical planning, you take x-ray and you do careful surgical technique and gentle handling, specifically when you do sinus lifting. Okay. Immediate management, small perforation, and diagnosis. So this is important because they will ask you tons of questions in this area. So we are going to deal with the perforation according to the size. Okay. There is something called Schneider membrane. This Schneider membrane is the soft tissue lining of the maxillary sinus itself. So when you suspect oro-antral communication, you should check the size of it because the size of oro-antral communication will dictate how you are going to deal with it. So you might end up by a small opening, typically less than 5 mm in diameter. In this one, you are going to do blood clot formation, encourage a blood clot to form in the extraction site. You do suturing and suture to cover the opening, which technique you are going to pick here. Yes, figure of 8. And then you are going to ask your patient to follow nasal precaution. Advise the patient to avoid action that increase nasal pressure, such as blowing their nose or sneezing with their mouth closed. So before, they used to do what they call Valsalva test. Valsalva test is like you ask your patient to do this way, and then you look inside the oral cavity and see if the air bubble is coming from the extraction socket. So you think, okay, so this is a big perforation. Or you can pick it with your probe. But they found such technique to aggravate the problem. Such technique is going to make the opening wider. So unless you have very strong indication in the question telling you it's a big perforation, which means you did extraction and then it come with part of the tuberosity, or it come with a big part of the buccal plate of bone. So this, yeah, for sure, you have big perforation here. So you're going to do it in a different way. But usually the regular manipulation or management of this one to assume it's a small, unless you have other thing to indicate it's a big, or the question telling you it's a big communication. So you're going to end up in the next line of management. So we're gonna assume it's small communication unless the question telling you it's a big communication. In this one, suture figure of 8 is better, blood clot formation, nasal precaution, and medication for our patient. How about large perforation? A large perforation, typically more than 5 mm, sometimes giving you number of 7 mm. In this way, it cannot be closed by such techniques. You should do what we call buccal advancement flap. This, you elevate buccal flap and release periosteum and advance the flap to over extraction site. You make sure your flap is tension-free closure, and you ask your patient to follow nasal precaution and medication. So let's see this buccal advancement flap because it's really weird technique. So in this area, you see here huge communication between the oral cavity and maxillary sinus. So what the dentist did here, he cut a flap here, and again he followed the same rules. And then he released the flap from the buccal side. It's not like related to the tooth itself. Related from the, you see here, buccal mucosa. And then he stretched the flap here. You see this soft tissue, dun, 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 coming here, 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 and then suture it here. And then end up by this way. Okay, so you're gonna tell me you have exposed bone here. We don't care. We have periosteum here. It will, like later, because like you close it with this flap, so it will like regenerate by itself. It will be fine. Don't worry about it. But if you end up by any food coming from here into maxillary sinus, you will end up by more problem. So oral surgeon, they don't care about this like little stuff. You have exposed bone here. I don't care. I just want to close this one and cover what I did wrong for my patient. Okay, so this is what we call buccal advanced flap, and this is the technique of buccal advanced flap. When we do it when we have communication more than 5. Usually question saying 7. Will you do Valsalva test? No. Will you book the communication with the probe? No. This used to be a guideline. No. Up till now, we assume it's a small. Every time you assume it's a small, you do the plug with the alveogel and you do figure of 8 suture, and that's it. Otherwise, if you see like some wording indicating it's a big communication, so you are going to think about buccal advanced flap, as you can see in the previous picture here. Okay? Okay, so that was everything for this chapter. This chapter is critical. Please, please, if you want to study just one chapter from surgery, this is a chapter to study. And the following one of fracture. Please study it well. Okay, thank you, and see you in next chapter when we discuss about the fracture. This chapter is not so big because I think the first 3 chapters are so big. This chapter is not very heavy, but it has a lot of information that you need to know. Thank you, and see you next chapter.